Hello, everyone. Thanks for joining us today. This is another installment of our Q&A about COVID-19 and COPD with our medical experts. So let me take a moment and just introduce our speakers today. Dr. Valerie Press is Assistant Professor of Medicine and Pediatrics at the University of Chicago. Dr. Press also practices as a hospitalist in Chicago and has been treating patients during the COVID-19 pandemic. Then we have Dr. Barbara Yawn. She's the Chief Medical Officer of the COPD Foundation and guides us in a variety of projects. She has a strong background in research as well as in family medicine. And then we have Dr. Byron Thomashow. He's a professor of medicine at Columbia University Medical Center in New York. Dr. Thomashow is a co-founder and senior medical advisor for the COPD Foundation. Okay, so Dr. Thomashow, this question is for you. Is there a way to differentiate COPD exacerbation from COVID infection? The person says it might go a long way in avoiding anxiety and reducing the trials and tribulations of specific care.
That's a really important question and a really good question. And the answer is sometimes it can be difficult because the symptoms can be fairly similar. There was a recent study, for example, that suggested that 96% of patients with COVID will have some combination of fever, shortness of breath, and cough. And each one of them was present, in 40 or 50% of the time. So it's very common to see those present. Shortness of breath and cough are classic features of a COPD exacerbation, but there are differences. So fever, especially a significant fever, 101 higher fevers or 101 or higher, is really unusual in a typical COPD exacerbation. And when you see it in a COPD exacerbation, you need to make sure that they don't have a pneumonia with that. So fever is not a typical feature of a COPD exacerbation, but is very common. Not always present, but very common in a COVID exacerbation. In a COPD exacerbation, the cough is usually, not always, but usually a productive cough. And oftentimes with COVID, it's a dry cough that you have. GI side effects are relatively unusual in a COPD exacerbation and can occur. They're not common, but certainly can occur in a COVID exacerbation. And perhaps most importantly, most of my patients, and I assume most of you guys out there, know what a typical COPD exacerbation is for you. And the further away that gets from your typical exacerbation, the more features you have, which are different than you'd expect, especially if there is indeed a fever with it, the more you have to wonder whether there's something else going on. That's what I would probably say. I would also stress with you that there are other viruses out there, and you can have those symptoms and not have it be COVID. So I don't want anyone panicking over this. Everyone needs to relax with it. The likelihood is, even if you got COPD, that we're going to get through this together. But there are some clues. I would also suggest, and Barbara and Valerie could comment upon this, that that's one of the things you should talk to your doctor about, your provider about in advance. I mean, that's the sort of thing you should talk to about anyway. What should I prepare? What should I have at home just in case I start feeling not right? What steps could I take to prevent it from getting worse? That's a conversation you should always be having. It's perhaps more important to have in the COVID world that we're living in now. So you set up a plan.
Well, and I assume you also tell your patients, even if you usually would take care of the early exacerbation at home, maybe they have some drugs at home to use, that probably in this day and age, in this pandemic, they ought to call and talk to your office, because you may choose to have them tested. Because I can imagine a scenario where somebody, it's not exactly typical, you don't know for sure, you have them tested, you go ahead and treat them for the exacerbation. And in Minnesota anyway, we're having to wait 5 days for results to come back. And then we know in 5 days, well, maybe it wasn't just a COPD exacerbation, it was also COVID, and we can deal with that. But I assume that you'd like them tested.
Yeah, I think that's a good point. I guess my concern is that the testing is still not where it needs to be. We really need a point of care test where the results are trustworthy, whether they're available back within an hour or two at the most. You know, what you've just described, Barbara, 5, 7, 10. I've had patients wait 10 to 14 days before they get a COVID test result back. Not only does that impact your ability to talk to them about it, but it makes contact tracing completely impossible. So, you know, I think we need to do a much better job with that. Valerie, I assume that that you agree with that.
Yeah, I think that's outstanding. I think one of the things, and hopefully you can hear me, that is important to consider too is if patients do get sick enough or need to come in for healthcare, that a lot of our healthcare centers are trying to triage based on whether patients may be at risk. So I know that in our outpatient center, for example, if patients are presenting with any possible symptoms that could overlap with a COVID infection, they get detoured to another part of the hospital. We don't want every single one of our patients with COPD to not be able to get to their usual care. So having that testing faster and more available would allow us to test and then allow them to continue on in the normal healthcare that we want them to get. So I think fast testing is important. I do think that another thing that we've been advising is, I loved your point about most patients really know their own exacerbations. And so they can take that into account. And I think it's been also okay to say, you know what, if you're concerned, and you're able to, while you either get tested or while you wait till the symptoms improve, is to close that bubble up a little bit, right? So that you can try and avoid infecting others on the off chance that you have the infection.
Yeah, I think that all those are really great points. You know, the other thing that's worth stressing is that the COVID test, especially early on, has gaps. It's, you know, that may be 20 or 30% negative. That's not really a false negative. It's just early negative, if you will. And, you know, especially when all of us are concerned that there's been a lot of press about how the message has been changing over these course of months. Well, we've learned things. We're not used to a disease that spreads pre-symptomatically. And I want to stress that term as opposed to asymptomatic. Asymptomatic suggests you never get any symptoms. Pre-symptomatic means that for 2 or 3 or 4 days before you become symptomatic, you may very well be spreading this infection. That's really different from things that we've seen before. And unfortunately, since early on you may have a negative COVID test, you need to weigh that. So if you need to take caution. If you've been exposed, if you think you're at risk, you know, if you've got symptoms certainly, or even early symptoms, you need to take precautions about being careful and not spreading, because you still may have it even if that first test is negative.
Thank you guys so much. I have a question for Dr. Press. Dr. Press, if you've had COVID-19 once and you've recovered from it, are you able to get it again?
That's a really good question. And when I was taking care of patients in the inpatient setting, that was one of their most important questions. And I'd be happy to hear from my colleagues. I've looked into this extensively. I think the short answer is probably, but we don't know the timeline. So let me explain. As has been previously mentioned, there are other coronaviruses out there, and it is possible to get some coronaviruses and get it again. The immunity to specific coronaviruses can be on the order of months. Some can be longer. With specific to COVID-19 infection, we have had instances of patients becoming infected, testing negative weeks or months later, and then weeks or months after testing negative, testing positive again. And there's been conflicting reports as to, is it that same initial infection that just for some reason you had some negative testing, but now you're testing positive and it's just part of the continuum of that initial infection, versus have you actually recovered from this specific COVID-19 infection and now you've recovered fully and now you have a brand new one. Again, my colleagues may know more, but one of the things that is going to be very important for vaccine development and for treatment and just for telling our patients how to be cautious is, can you get this specific COVID-19 infection again, and what's the timeline? And I think the short answer is we're not entirely sure yet of that timeline and the exact answer. Other thoughts from Barbara, Byron?
Yeah, I think that what you've just said is true. I wish we could give more definitive answers to it. There has been some data suggesting that people who recover for it only carry those antibodies for a matter of weeks to a couple of months. I think that one of the drives with the vaccine is to develop a stronger, if you will, immune response that might last longer, or again, give the concept of re-vaccinating them at some points in time. I've already stressed the fact that we have concerns about the testing. One of the things I think which has been very frustrating to all of us is the antibody testing, which, has left a lot to be desired. I mean, there are times where you think you're just flipping a coin as to whether or not it means anything or not. So I think that's frustrating because you had an antibody test that you could trust. I think it's fair to say that you would have some degree of immunity for a period of time if you were positive. And you could then put that together with younger, healthy people and say, well, that's the group that could go out and potentially teach, potentially go back to work. You could put all this together based upon science as opposed to based upon guessing.
Yeah, and the other thing that I think we have to always think about is mutations of the virus. Is it going to be the same virus? I mean, we go through this with influenza on a regular basis. Are we seeing and are we going to see this with the SARS-CoV-2? And I think the answer is we don't really know yet. But maybe, again, as you both have said, as we have more science behind it, there are more of these people who we know the exact genetics of the virus the first time, and then when they get a second set of symptoms, I think it will be very helpful. And we all feel so frustrated by what we don't know right now.
Yeah,
That's true.
If I could add to Barbara's point, because I think she's certainly correct that we're very frustrated by all of this and obviously saddened by some of the states and cities which are obviously so bad. But I want to stress, and I assume my colleagues would agree, we have learned a lot in the last 6 to 7 months. I think it's really important to know that. Not only have we made progress with vaccines, and we are making progress with vaccines, we have 2 drugs now that we have a lot of data that work. Remdesivir, an antiviral agent, and even an old-fashioned steroid called Decadron. And there is good data now that in hospitalized patients who are quite sick, that those drugs can make a difference. There are more things that are being studied out there. There are cholesterol-lowering drugs. There are, famotidine, a GERD agent. There are things we're looking at that may make a difference. And perhaps most importantly, and Valerie could comment upon this as well, we've learned how to manage these patients a little bit better. So the concept of prone managing patients, of switching them from their back to their stomach, does make a difference, especially when you have sick enough patients to put on a ventilator. We've learned that rushing people to a ventilator when you have the option of giving them higher flow oxygen is probably not a good choice. So we've learned how to manage these people better. And hopefully that will be reflected, in better results down the line. It would certainly be better, and I'm sure we all agree, to prevent people from getting the infection. That's why the masks and the social separation and ultimately the vaccines are so important. But if they do get infected, there has been progress made, and I'm absolutely sure there will be more progress made.
Absolutely agree.
Thank you. Dr. Yawn, I have another question for you.
Yes.
This one asks, besides age, what are the other risk factors for severe disease, and what can I do to diminish those risks?
Well, when we talk about this, we need to start talking about modifiable risk factors. There is data that things like race, perhaps, like obesity or being overweight and having chronic diseases all put you at higher risk. Well, we really don't know how in the short run to modify most of those things. So the risk factors that we do know how to modify are not receiving a large exposure. So that means staying out of big crowds. That means wearing a mask. That means having other people wear masks. And if you are around a smaller exposure, making sure that you wash your hands, for example, when you take your mask off. So right now, I think the things really get back down to the simpler and I don't know if it's simple to get people to do them, but they are simple if you decide to do them, of wearing a mask, social distancing, good hand washing, and trying to get people who are ill to make sure they quarantine so they don't spread it any further. But I think those are really the risk factors we can do anything about, because I don't know how to change my age to younger. I don't know how to lose 50 pounds in the next 2 weeks. But maybe Byron and Valerie, do you have other things you'd like to point out?
If you could figure out how to make me younger and get me hair back, Barbara, I will be perfectly happy with that.
I don't think having loss of hair puts you at higher risk for
I don't
COVID,
think
though.
so. I guess the only comment that I would make is most of these things are not really reversible, and you're right about that. But you could make an argument that the better you control your asthma, the better you control your COPD, the better you control your diabetes, the better you control the hypertension, the more likely that you're going to be in a better place. And that comes back to what Valerie mentioned at the very beginning, and that is one of all of our concerns is that usual healthcare is not being done to the same level because of the understandable fears that are taking place. And I understand that, but I think that the only thing I would add to Barbara's comment is doing the right things for your own medical problems will help.
I agree, and I think one other thing I would just add to the list that's relevant for some of our patients with COPD is smoking. And again, it's not a modifiable risk factor that'll change overnight, but if we think about long-term well-being and avoidance of COVID infections or other infections, it is modifiable, very, very difficult to modify and to stop smoking if you smoke, but that's another example of taking care of your own health that could in the longer term pay off.
So Valerie, let me ask you a question about that. Maybe Barbara has a comment as well. We're seeing more younger people develop the disease. There always were some, there seem to be more. This is probably more of a social issue of they're going out to bars and parties and things like that. I understand that. But I've been wondering about the role of vaping, for example, which clearly has its own risks. Have you seen anything tying that to the COVID? Barbara, you can comment as well.
Yeah, so I've seen two things. I've seen some sort of anecdotal, more like news stories than research stories on younger people. Some of them are being inspired to quit smoking and to try and quit vaping in the hopes that that would help. And then other kind of editorials sort of saying we should put some effort into helping our young people quit smoking and or vaping because they are more at risk. And then I have just one colleague who's interested in the severe vaping-related lung disease that's been happening and whether that could coexist with COVID-19. So there's going to be some research into these populations, but I haven't seen actual data on these topics yet. I don't know, Barbara, if you have.
No, I haven't either, but I think it's very, very important. And in Minnesota, for example, we are having a very large switch from adults in their 50s and above to adults in their 20s and 30s. And as we get more people, there will be, I think, more research on whether smoking is an important issue in those younger adults. And we all know smoking is bad for your health, including the people who smoke. And we also know that sometimes an event, for example, a heart attack or a stroke, can get someone to stop smoking when they couldn't do it any other time. So if that's possible, maybe a fear of COVID can also just be used in a positive way to get people to stop smoking. And I'm not above trying that if it works.
The only other comment I would make here, guys, is coming back to the young people and the higher incidence we're seeing, is that they may well be less likely to die. They are less likely to die, although we have all seen, unfortunately, young people who have died with this. But there is also an increasing number of people who have survived it, who've been left with damaged lungs. There have been people who've been left with some neurologic damage. Now, these things may get better with time. We're still very early on in this, but death is not the only bad outcome that one could see. And I want to stress that with any of the younger people listening, because there are risks.
Yeah, my son is a family doc, and he obviously is younger than I am considerably and sees younger patients. And he said he has seen several who 2, 3, 4 weeks later are still having significant disability from the COVID. It isn't necessarily the cough anymore, the fever, the chills, but the fatigue and the inability to do their usual activities for long periods of time. So it is more than just being in the hospital and dying that are really adverse outcomes from COVID.
Yes.
So thank you so much for joining us today. Again, if you have any questions, you can visit our website at thecopdfoundation.org and visit our section on the coronavirus updates. Thank you, and bye-bye.